Hi, everybody. It is Dr. Rebecca Griffith, the ED and we are back here on our newest episode of Admitted or Not. And I'm so excited to have with me today Marie March, all the way from New South Wales, Australia, right?
Yeah, that's right. Eastern Seaboard.
So, literally, we're recording this on different days.
Yeah, well, it's Thursday here.
Yeah, and it's Wednesday evening here,
Yeah,
so that's crazy to
yeah,
me that you're in a completely different day than I am. But welcome. Why don't you introduce yourself?
yeah. Thanks, Rebecca. So I'm Marine. I work as a senior physiotherapist into public EDs in my state. On my spare time, I happen to be working on a PhD as well. So yeah,
Well, talk to us about your PhD before we get into all the ED stuff, because that's amazing that you're balancing that.
yeah. About 8 years ago now, I had two little ones and was getting very bored with clinical work and decided that a research degree would be a good hobby. And so since then, it's snowballed from a master's to a PhD. I'm exploring how psychological health before surgery affects recovery after total knee arthroplasty, um,
Interesting.
taking a health services perspective. So really informed by my clinical work up until that point. So it's taken me on all sorts of adventures. I've been surprised at how much of the psychologically informed physio we've developed as part of that PhD I've needed to use in the emergency department. You never quite know how you're going to apply things until you are in the situation with the skill.
I think that's a really good point, and I want to dive into that a little bit more. But I think what a lot of people want to know is what is different on the other side of the planet in the emergency department, because my impression as an American is that we are woefully behind in emergency PT practice compared to other countries. So I'd love to hear like what your practice looks like.
Yeah, and I think in Australia it's important to consider that there's huge variation within states and across the nation. So we have a state-based health system. So hospitals in New South Wales look different from hospitals in Victoria.
Hmm.
Hospitals in rural New South Wales look different from hospitals in the cities. So, I've got commentary on the places I've worked, but not necessarily the big scope. The majority of emergency departments in Australia are in public hospitals. So we have a universal healthcare system. And so most of the ED practice is in that context. So that means the majority of people who come to seek care don't have to pay for our time or for the privilege of presenting or for the investigations. There are some small exceptions to that around overseas visitors who don't have insurance, but the ED visit itself is kind of hundreds or a couple of thousand. If you come and you need orthopedic surgery, it might be 5,000,
Oh my
maybe
gosh.
10. So even for the people who have to pay for us, it's a very different ball game. Having said that, we still have people who struggle with paying for things like crutches and hand boots that we prescribe. So that context is very different. And I think the other thing is around prescriptions. So there's physios and certainly our OT colleagues often prescribing equipment.
Hmm.
So in the majority of hospitals that I'm aware of, there's some sort of loan pool arrangement where you could, borrow a frame or a shower chair from the hospital for a fee, so say $50 or $60 for a short period, and then give it back to us. Or if you
Hmm.
went and bought it, it would be under $100. And we can do that independently. We don't need to check with anyone else about whether that's appropriate. So I think
That's amazing.
that's a huge difference. And we're not calling insurance companies to say, is this covered? So
So
that gives,
when people come to the hospital, they can just come in and get
yeah,
all the care they need, regardless of their ability to pay.
correct. Yeah.
That sounds
And
amazing.
and I think we take it for granted. And the US health system sounds incredibly scary coming from that context. And I think it's
Uh-huh.
important to mention the downside of the universal healthcare system, which is that waiting times are huge and blow out. And at the moment, with a post-COVID world and our general practice world kind of really struggling with that side of things,
Mm.
the volume of people coming through ED is much higher than it used to be because of the lack of people being able to get to the GP. So that means people are waiting a long time to be seen. They're waiting a long time to go home. There's bed block in the hospital. So even if you've been admitted, you're probably stuck in ED potentially for a couple of days. And if you're a younger person who's fairly mobile, you might be stuck in the waiting room for a couple of days, waiting for bed or waiting for surgery. So there are definite downsides, if I can put it that way. But
I mean, I
certainly,
wish I could say that that wasn't the same here.
yeah. So I feel like paying for that is different. Whereas if it's free, we kind of go, well, you're not paying for this, so stop complaining. That's not a
No,
reasonable thing
because
to
I
say,
mean,
but it's
we're having boarding, we're having capacity issues. Like I had a patient who had an ACL tear who, oh, his knee was actually quite unstable. Couldn't get an orthopedist appointment for 6 months. You know what I mean? Like, and we are also seeing that increased volume of patients who can't get into their primary care. Like they have, say, like a urinary tract infection, maybe, but their primary care is like, we can see you in 5 weeks. So that is not unfortunately exclusive to your healthcare system.
so we've got issues across the world, I think. I'm not sure what the answer is. It's a bit bigger than one profession, but system change is hard. And system change in the complexity that we have here with the difference between primary care being funded by federal government and state healthcare funding hospitals means that there's no incentive in Australia to sort out that mess because different people are paying and there's a lot
Yeah.
of cost shifting.
Well, you mentioned too that there are prices for people who may be traveling overseas. I actually had a patient this last week who was traveling from a country with a socialized healthcare system and needed actually advanced imaging. And their traveler's insurance policy did not include that. And they were refusing imaging because they were afraid of the cost of the US healthcare system, and this poor person had taken like extraordinary measures to try and avoid coming into our hospital, with which I thought was just like a not a great commentary. Like they had tried so hard to try and maybe get back to their home country so they could get the care they needed. So gosh, tell me how
Yeah.
that informs your PT practice in the emergency department, though, because like I know that I have to look at people's payer source when I'm making decisions. I can make all the recommendations I want to, but they're not realistic if we don't take into account people's their payer source or their ability to pay.
Yeah, and I think kind of need to. So I guess clinical risk is a big thing for us. So we want to minimise that risk wherever possible. And if pulling out some secondhand crutches or just not worrying about whether they paid for a $30 pair of crutches means that we've minimised risk, well, we'll just cop that, I think.
Yes.
And I think often it comes down to patient autonomy. So if we've recommended a frame and someone's chosen not to take that, instead of framing it as a financial decision, which it might be, we frame it as a patient autonomy decision.
I like
So
that.
we can't force people to do that or take it. And they've got to sign stuff that they're going to bring things back. And I think just the logistics of hiring stuff in our context, especially after hours in the emergency department, is that we can just say to the hospital, send them an invoice and you guys deal with the money. You guys can have that fight. And so we don't necessarily get stuck into the nitty gritty. And I think the other thing is, in the past few years, kind of supermarkets and kind of lower discount stores, so I guess the Walmart equivalents, if you like, start stocking things like a basic walking frame or a toilet seat or something like that. So there are lower cost alternatives out there. Secondhand shops, do a roaring trade in walking frames. So if it's clear that the payment factor is there, I kind of encourage people to think outside the box and look at those sources and borrow around. There's always my grandma had my crutches for a knee replacement, so I'm going to borrow them because I've done my ankle at football. Yeah. So yeah, just helping them to think outside the box.
But what happens if, say, you have a patient who needs home care or they need to go to a rehab facility? Well, how does that work?
Yeah, so services here are funded federally. We send a referral, and they generally get accepted unless there's a really extenuating circumstance or the patient declines. But there also is a really finite number of services available that are short term. So, generally on Mondays that it resets. So if you come in needing services on Monday or Tuesday, it's really good. If it's Friday, that makes it a little bit trickier. And those longer term services are funded federally as well. And we can't really set them up from the emergency department. We could put in a referral and then it's just up to the that service provider about assessment and prescribing that.
Mm.
In terms of rehab, we can't admit directly from the emergency department, although I
Mm.
think we would love to be able to do that. They generally need to be accepted for an acute admission under often the geriatrics team or a different medical team, and then they kind of get over their acute issues there, and then they go to inpatient rehab based on the assessment of the rehab doctors. So we actually can't do that direct referral anyway. My consultants can't do that direct referral. Even though there's some people who really do need it.
Yeah.
Honestly. Yeah.
Interesting. And then when you and I have talked before, you said that there are different types of physical therapists or physiotherapists where you are.
Yeah. So in our particular setting, we've got a physiotherapist who's been in a primary care role, so that for about 10 years. So they're someone who, after the patient gets triaged, the physio acts as an independent practitioner and can pick up that case, takes responsibility for their care, and is kind of their treating professional, similar to the way a nurse practitioner might do it, similar to the way a doctor might do it. More recently, we've actually put an allied health team into the emergency department that takes more of that secondary role. So, and that's the role I'm in at one of my sites at the moment. So we don't take responsibility for the care of the patients. The doctors generally do. But we're there to do musculoskeletal assessments, vestibular assessments, mobility assessments, falls assessments, all that discharge planning stuff to try and get people home from the emergency department supported rather than admitted for potentially, 2 days to a week to do the same stuff we can do in the emergency department.
In an overfull healthcare system.
Yeah.
So one is a primary provider role, and then one is more like a consultant.
Yeah, I mean, the word consultant in Australia means like specialist.
Okay.
So top of the tree doctor. But yeah, so in a similar way to the inpatient physios in a lot of ways.
Okay.
Yeah.
And are there any educational differences? Are there any scope of practice differences? Like does the primary provider PT prescribe? Can they order imaging? Like what are the scope of work differences?
Yeah, and this is something we're struggling with in Australia. So the primary provider roles, there's no kind of registration or professional pathway that you have to have before you do that role. You just have to go and get the job, really. So demonstrating a very high level of musculoskeletal assessment skills is the main criteria. But we don't have the idea of board certified. That's not a thing here, and we don't have an ED specialist pathway either. They do have prescriber rights for X-rays. They do generally talk to, say, orthopedic or plastics doctors when they need to, so they contact them directly. They can't prescribe medication. And for advanced imaging, I'm fairly sure that they need to talk to medical teams in the ED to get them to order it. But yeah, the more advanced stuff. And they're working fairly closely with doctors in that setting anyway, so that they've got another set of eyes to bounce cases off. And certainly when medication's needed, as it inevitably is, they're working closely with the nursing staff as well. So yeah, but I think that's different depending on your setting, and they're different in different states. There are different levels of practice as well. So yeah, that's kind of where it is in my setting.
That's amazing. So when you went to PT school, was this a job that already existed? Was this like an area of practice you knew about? Like, was it something you could go into right away?
I think I'm going to give away my age by saying I don't think it existed very much, if at all, in my state back then. So I've kind of grown up and worked and gone to PT school in the same state. So no, but when I was at uni, I kind of had this aspiration to be the only physio in a small town who does everything and has that really broad scope of practice.
Yeah, I love that.
And then I married someone who will only work in a big city, so those dreams got put aside. So the short answer is no, but I think as more and more physios work in ED, there's more awareness. we're still not really getting physio students in the ED at this point. COVID is a big
Interesting.
reason for that. But I think we're hoping to develop that in the future. And I remember watching one of your previous podcasts talking about that kind of idea of which students do we get in the ED and how do we do that.
Yeah.
Yeah.
How do we facilitate that the best way we can? It's tough.
Yeah. How do we keep everyone safe? And I think in the ED settings where I work, one in particular, there's a lot of safety issues because, you know, we're based in the acute setting. We've got a lot of people in acute mental health crises, people in restraints, police everywhere, security everywhere, people with dementia and delirium who have behaviours of concern.
That was a very nice way to put that.
So that's kind of how, like, that's kind of we've got this idea of code black, which is like a security personal threat sort of
code gray for us.
Yeah, and so behaviours of concern is what we document when we see the signs that might lead to that. So yes.
Yeah, I think ours are listed as yellow flags or FYIs, like history of violent behavior, history of aggression towards staff, things like that. The other thing that I see a lot is substance abuse issues causing some of those behaviors of concern as well. And I think in some ways it's very good to have a student be exposed to that so they can see some of that part of healthcare that we often gloss over in physical therapy school. Like we talk about mental health briefly, and I really appreciate your thesis work because I think it's critical that we learn more and more about psychological aspects of care. So how are you using that in the emergency department? I really want to hear more about that.
Yeah, so I guess my work has kind of broadened a little bit to kind of musculoskeletal and osteoarthritis in particular. And so bringing that research work into the clinical assessment where you've got an older person who's got OA, who's had a fall, they're essentially having an EOA flare. So bringing that education to that space, and it's not just you don't have a fracture, off you go. It still hurts and you still need to do things to get better. Yes. And this is the follow-up you might want to go to help you be guided in that. Also, I think stuff around chronic pain, particularly the back pain as well as some EOAs. So I developed a novel intervention called Compact as part of my PhD, which was kind of taking the best of kind of psychological physio and applying in that pre-op space. And we used acceptance and commitment therapy as kind of our kind of theory behind that. And so that has some really helpful things around how to develop therapeutic alliance, which you absolutely need in the emergency department.
Quickly.
So, yes,
very quickly.
Very quickly. How do you show empathy? And that's an important thing, rolling with resistance, not telling people actually you're wrong. This is what you need to believe and kind of
100%.
So there's kind of that component, but there's also kind of these ideas of making sure that people understand that the psychological aspects are going to affect their pain, and that if their anxiety is not under control, their pain probably isn't. And in the context of sort of acute trauma in a very broad sense of, you've had a fall and all the kind of drama that comes with, having a fall, calling the ambulance, being in a collar for 4 hours, waiting for your CT, all that sort of almost theatre in a way, which is important for, preventing spinal injuries.
Yes.
That brings kind of this big, psychological hurdle. And so when you're the person who takes a collar and go, okay, you can walk now, let's go, there's kind of that adjustment of, oh, it's safe now, and, talking people through that.
Little psychological whiplash.
Yeah. And, can I go to work? And so who in the ED is educated about whiplash, prognosis, recovery, flagging the impact of event scale? That's the physio. No one else is doing that work. No one else has been doing that work. And you're often the person with the most time to spend with the patient, I find. And so just spending that time with them makes them feel like they've been heard, makes them feel like they've had a thorough assessment. So that's actually very therapeutic in itself. And in the ED, complaints management is a big part of it, more than other places. So preventing that complaint or being that advocate when people feel like they aren't heard by the rest of the team is another part of what I do.
So if you were going to tell somebody your secrets to establishing trust and rapport and that therapeutic alliance quickly, like what are your top 3 tips?
Oh, golly. So I think being really conscious of body language and eye contact and being on their level. So I think often older people, particularly who are flat in bed, we kind of come and stand over them. And I think that's really not desirable, and it doesn't
Agreed.
make them feel empowered. Having said that, I try and make sure that people, when I introduce myself, if they're in that position, I do kind of stand in a spot where they can see me, but then try and be near their ears at least, so that there's not that power dynamic. So just being really cautious about that. So that might mean actually kneeling or being lower than them so they feel like they're in that position of power.
I kneel a lot.
Yeah, it's not great. I often start kneeling and then go, I'm going to go find a chair and come back. Yes, unfortunately, my knees are not strong enough to sustain it. But just starting off there, I think, is a really good idea. And I think sometimes it's helpful to, you've got to, when there's a carer or a parent or a family member, finding a way for the patient to still have autonomy and express what they need to without the carer talking for them all the time.
Oh, that's a great point.
We have a very diverse population where we are. I think in our local districts that we serve health-wise, there are over 150 languages spoken in our community.
That's incredible.
So, I'm not going to learn enough language in all of those languages to be culturally appropriate. But where I am aware, using Mr. and Mrs. to address people rather than first names, or being acutely aware of privacy concerns, particularly around women who may be from Muslim majority countries, or older men from those countries who might prefer me not to do things because I'm white and a woman, or just acknowledging that and saying, is this okay?
Yes.
And so a lot of kind of, this is what we're going to do, is that all right? And do you want curtains open or closed, or we need to do pants off, are you wearing undies, this kind of stuff that feels really basic, but I think people are already feeling very vulnerable, and so helping them to feel like we're keeping those things into account is important. So yeah, it is a bit of a balance. And I think the other thing which is really hard to do is if you've said something wrong or given the wrong impression or made a mistake, actually owning up to that and going, I'm really sorry, I've said the wrong thing, or this is the right thing, my apologies, and just owning up to that early. And when I've had to do that for my own conscience just as much as anything else, people have generally received it fairly well.
I find that to be the case as well. Or if some service recovery is needed from something else that happened while they've been there, I find that like taking some kind of ownership or responsibility for that, even if you weren't involved in that at all, can help patients kind of recenter a little bit.
Yeah, and I think also the waiting kills people. Figuratively. So keeping them just updated with, this is what we're waiting for, this is where we're up to, I'm waiting to, is the other thing. And I'm reminded of a recent case where at 8 o'clock in the morning, someone referred me, this person who'd been in the waiting room since 2 o'clock the previous afternoon, waiting for a particular appliance that we didn't actually have in the hospital. So there was a comedy of errors there, but actually being very upfront with the patient, going, this is the problem, this is what we're doing to solve it. I'm sorry that you've had to wait in a chair. I think, and also then going, well, in terms of follow-up, I'm going to throw the kitchen sink at you. Have some equipment, have the hospital and the home service, have some service providers if you want that, here's our number. Just kind of not entirely going overboard, but just making them feel cared for, at least when they leave, so that they leave on a good note.
Man, that is tough. That is really tough.
That was a big day of learning for me, but we did get her home and happy.
Good. So, gosh, that's crazy. What would you say in your setting that are the skills that are most needed for a physio?
Yeah, so I think having a really strong discharge planning framework. So, and that's kind of a strength I bring from many years in inpatient. So knowing what's available locally, knowing how to get it, and having a bit of a transdisciplinary approach to that. So because I'm working in a team with OTs and social workers, and because of the difficulty around rostering and stuff. Like I'm often the only one working. So if they need an OT, I don't have one to call, but actually maybe I can ask them about their bathroom setup. I know which things I can prescribe and which I can't, and I know how to get the OT to come to their house. So being a bit more holistic around that. The other thing is very strong musculoskeletal skills. I think the musculoskeletal skill set within the emergency department is very variable in our state. And so when we're working in a context where they're relatively weak in MSK, they're looking to the physios of all kinds to be strong in that and to give reassurance, and they rely on our assessments. So kind of having a strong ortho inpatient background helped with that, but also have spent time in outpatients and many years in fracture clinic. And I think that's the other thing. In New South Wales, we do casting, which is unique in Australia, and I think it's probably unique around the world.
Yeah.
And so that's a really core part of a job in physio from as a new grad. And so casting is a big part of what we do in the emergency department as well. And it's got that extra layer of pain, acuteness, wiggly kids who may need sedation of some kind. So, and a bit of reduction and molding as well. So being confident with casting is a really big part of it. I'm increasingly finding that vestibular skills are really handy, and that's certainly not one of my strong points, but I have been appropriately told by you and your other ED colleagues who are strong in your own vestibular that I need to get onto that.
Yes.
So that's a post-PhD project.
I love that. I love that. Okay. So I think we're ready for the case. And you said this was like a big win, so I'm excited to hear.
So it's kind of a big win, but in the context of a broken system, I think.
I love that.
Yeah.
None of us are working in a good system, I feel like, so.
This is true. And I think it draws in a lot of different aspects. So we had a tween boy who had been in the emergency department for 24 hours with a lower limb fracture that needed surgery ultimately. But at 24 hours, the orthopedic team decided that he could go home and come back for surgery in a few days' time because they didn't have surgery spots available. And we didn't really have any inpatient beds either. This boy had reasonably severe autism and was minimal in terms of his verbal output. He was over 80 kilos and about my height.
Oh, wow.
And kind of came from a native home where, language other than English was their native tongue. He also had split custody between mum and dad, both of whom lived in double-story townhouses with a bathroom upstairs.
Poor thing.
And they were tired, like they'd been with him in ED for that long. And he was non-weight bearing as well.
Was there any concern for like child welfare, or was it like an accident?
No, it was an accident and a fracture that was not indicative of non-accidental injury. So he was in full knee extension, non-weight bearing. So we had to get him home. So that was my job one day, and we did it. So he went home on a pickup frame. He could.
What is a pickup frame?
So a frame with no wheels.
And a frame is a walker.
Yes.
Okay.
Yes.
I'm like, because when you said pickup frame, I'm like imagining a truck with something on it, like a pickup truck.
Pickup. Yeah.
I'm like, a pickup frame. Like, what is a pickup frame?
Yeah. So the classic
I thought maybe
Zimmer
it was
frame,
something that like lifted him up.
Oh, if only. Yeah, but I wish we had those in ED sometimes.
Right.
The classic Zimmer frame, if you like. So he could actually manage that reasonably well, and I think how good someone non-weight bears in this scenario is a very very nebulous thing.
Yes.
So we got him walking. We got mum and dad happy that they would manage at home with a way to shower, because smelly teen boys can't go that long without washing. So we did it, and we haven't heard anything since. So I guess it went okay. Also, the other thing I think in that context is, can he get to school? And I think
Great
that
question.
we have a lot of kids with disabilities in our area, as well as a lot of group homes. So that's
Hmm.
kind of supportive accommodation. And so ensuring that kids can get to school, whatever that school setting is really important for respite for the parents.
Hmm.
Because we really need those parents to be going to work if they're at work for their own health and long-term financial well-being.
Yes.
So not everyone can drop everything and keep a child with high needs at home for 6 weeks or more. Like, that's not realistic, and we should be
No.
expecting them. And kids who need routine, school is part of that routine. And I think the advantage of support classes and kind of special schools is that when you say, oh, this child can't walk very far, they need a frame, they need a wheelchair, they're like, oh, yeah, that's fine. We've got ramps, we're used to it, high needs kids. Whereas getting kids who are mainstream back to school on crutches or wheelchairs is often a much harder thing, because there's a lot
Hmm.
of exclusion in those environments. So, yeah, I think bringing some life experience around that we've had to that setting, and encouraging parents to advocate, no, your kids should go to school, actually. This is
Hmm.
not a reason to miss school. Or, give it a few days to make sure their pain management is appropriate and well controlled. Then they can go to school on this day, and this is how we're going to get there. So having that conversation with them, because no one else is going to have it with them. The school will expect
Right.
them to have the answers, and no one else is going to give them the answers. So yeah.
I love that. I actually have a kiddo with autism, and so imagining, and he does great, right? But like imagining him having like a huge change to his routine, to be dealing with not being able to weight bear, like I can imagine all kinds of sensory impacts that would have, how many disruptions to his routine. Um, so I have a lot of empathy for that case. It sounds like you did an incredible job. And I think the bottom line there is that even if you could have maybe had a room for him, maybe in his case, being home was the best choice and the patient focused choice.
Yeah, and we've had a few young people with ASD, among other diagnoses, in the inpatient setting, and we're not really well equipped to understand them or to deal with them. And having seen some of those things play out, I was pretty keen for him to go home as well. And I think,
Yeah.
having been in fracture clinic for a long time with a lot of kids with ASD, approaching them with a car saw, this loud, buzzy thing going, I'm going to come at you with this and get this thing off your arm.
Hmm.
And then in the back of your mind, thinking about things like least restrictive practice. Yeah, I'm often finding myself asking kids who I feel like I have a pretty good radar for these kinds of kids. And so being proactive and asking parents and kids, oh, do you have any sensory needs, or, what's he like with loud noises, and how do we go with vibration, and that sort of thing.
Hmm.
Um, just a little bit of consideration can go a long way. And
I
I think,
appreciate that.
yeah, there's always uh, kids where, you do actually end up having to restrain them more than you would like. And, we've had a few kids who tried to do a runner, and fortunately one of my colleagues is very tall, and that helps a lot.
Oh,
But yeah, it's trying to do what needs doing in a safe way.
right.
Yeah,
In a
yeah.
way that you're not adding more harm.
Yeah, and I guess now, since we last spoke, I'm also working at a hospital that sees more children, and so um, and working with a child life therapist, I'm now aware of, well, when you're
Ooh.
having those encounters as a child with a hospital, if there's something that kind of doesn't go right, or there's a lack of trust or some trauma,
Hmm.
that keeps growing, actually.
Yes.
And so actually, trying to prevent that as a child is super helpful as
Yes.
they grow into teenagers and adolescents. And especially if they've got long-term needs where they're going to need to keep coming back, you actually need to get
Yep.
into that. We can't actually dismiss that, because then we get adults who, don't want to get immunized or don't want to come to hospital till it's too late, and they get more trauma, and it
Yeah.
cycles.
I
So,
think that I did some precepting at a clinic for the uninsured here in Colorado, and their motto was as much as possible for the patient, as little as possible to the patient.
yeah.
And that really stuck with me. And particularly when dealing with people who have different needs for whatever reason, just
Mm,
what can I do for you in a way that I'm not doing it to you.
Yeah, and I think for people who've been interacting with various systems, so for us, Centrelink is kind of the agency that's from the government that deals with, you know, payments for people who are unemployed and that sort of thing. And that's can be very paternalistic and people have had bad experiences, but often we're all perceived as government, so we're all the same. And so they bring that past bad experience to the hospital and there's that distrust there. And so even if people decline, just having a building some trust for next time is actually not bad. And certainly in Australia, when we've got kind of our Aboriginal and Torres Strait Islander populations who, for good reasons, have big distrusts of government systems.
100%.
Being just a little bit aware of that and being flexible to kind of work with them around how they would like their assessments and management plans to be enacted, and not continuing to challenge them when their decisions are not what we would have done. And just being clear about safety and just leaving their choice up to them.
I love that. I think that's a great summary too of just how we should be treating everybody. Like letting the patient be the one who's in charge of their decision making, giving them the best advice that we can, giving them the best plan of care, the most support we can, but then taking a step back and realizing that it is their choice and being respectful of that. I think that's amazing.
Yeah, and it's something that it's hard to shift, isn't it? Especially in orthopedics. I find, having worked with orthopedic surgeons for a long time, the types of people who go into orthopedic surgery kind of very much have that paternalistic view sometimes. And also we've decided you need this brace, so we're going to put it on. Like there's an assumption there. And certainly with some of the spinal braces we've come across, and people with COPD who have thoracic spine compression fractures,
Yes,
you can't be blanket prescribing a TLSO for a stable fracture.
I 100% agree, especially when they're for comfort. I'm like, what?
Yeah. So I kind of go, well, I'm very open to patients not consenting in that scenario. Because it's just, what we need to look at the risk and benefit. And I think, in an inpatient setting, we often have that risk and benefit discussion around, well, you don't want to get out of bed, that's fine, but there is a risk to that as well as a benefit.
Correct.
And getting up, if your blood pressure is labile, there is a risk, but there's also a benefit. And so framing things with both sides of that coin, for this particular action or treatment, what's the risk and benefit? But for inaction, what is the risk and benefit? Is sometimes helpful, at least as a practitioner, to kind of go, well, what do I need to say and talk about? And then patients can choose with the information.
That's great advice. Marie, it was so nice to have you on the podcast today and to hear more about how things are going. I would hope maybe one day that I could come and visit you and see how everything goes for myself. That would be a bucket list item for sure.
Yeah, book it in.
Any final thoughts?
Yeah, I think there's an adjustment to working in the ED coming from other parts of the hospital, but it's one that can be really rewarding. And I find that the variety keeps you really interested, and working at the top of your practice scope every day is really stretching yourself as a practitioner is actually something that's really rewarding and a good thing to be doing. And this is the room where it happens in a lot of ways, in the emergency department, and showing people what we can do as physios, and building that confidence there is something that I'd encourage people to explore, especially if they love musculoskeletal. And I think also working with OTs in that environment is something I would really encourage people to explore as well. I've had some wonderful experiences and benefits having some OTs alongside me, and developing that transdisciplinary approach is also a great avenue that we need to explore for our profession.
I love that. And for anybody who's listening who's never even thought about having an occupational therapist in the emergency department, the first episode that I did when I was trying to sort all this stuff out was actually with Julia Smith, an occupational therapist at my hospital. And we did that for OT month back in April. So look up that episode so you can hear a little bit about their amazing skill set and how it applies to this setting. And with that, I think we'll wrap it up. Thank you so much for being here. If you haven't subscribed to the podcast, please do. It's now available on all of your major streaming platforms. And we appreciate you listening. We'll see you next time.